Welcome to this masterclass focusing on studies of cardiovascular risk in people with ADHD. And the focus is on register-based studies. And as you will see, as you probably noticed by reading the three papers, we focus the discussion around pharmacoepidemiological studies. Okay. As you will notice also, me and Zheng will switch and do this together. I will start off with a brief introduction. Let's get started. So this is no news to you. ADHD is very common. We have many of us in this room and in many TIMESPAN members have demonstrated that ADHD is associated with lots of problems. I think the same goes for the next thing. Many of us have demonstrated that the prevalence of ADHD medication increase worldwide. And we all know that there are concerns around cardiovascular risk in relation to ADHD medication. Randomized controlled trials have demonstrated for many, many years that ADHD medication have beneficial effects, primarily on ADHD symptoms. But I think it's fair to say still that RCTs have provided less information about real-world consequences and the effectiveness of ADHD medication, both in the short-term run and also when it comes to long-term effects. So my question to you is why have RCTs provided little information? I have listed a couple of them. I mean, you mentioned, I guess, the first one. Interesting people are often excluded in RCTs. The sample size is an issue. Kenneth mentioned length of follow-up. And with that, I think Zheng just want to highlight a couple of key differences between RCTs and real-world studies.
Yeah, we see real-world studies, including registers, electronic health record, medical claims, all these sort of data. And I mean, we already mentioned a few sort of advantages of using real-world data, but these advantages comes also as a cost, and the major cost or challenge with real-world data is they are non-interventional, and there's no randomization, the allocation or assignment of treatment, and there's no comparator for in the analysis. So that creates a challenge for us to analyze the data and making inferences from the real world data if our target is the causal effect of the treatment or intervention. So we already sort of mentioned a lot of this. So if we sort of summarize this, RCT have very good internal validity in terms of making a causal inference of the treatment effect on the efficacy. That's the primary outcome usually, and some short-term safety measures. Whereas real world studies have good generalizability and is directly more relevant to the clinical practice and targeting a wider population and measure things happen during a more longer term follow-up. So we would like to sort of discuss a few examples that you see in the papers that we send around, and then think about the design features and also the potential issues underlying this sort of studies. Would you like to?
I can start. So this is a study that we recently published. So as the title indicates, it's about methylphenidate, not ADHD medication broadly. We focus specifically on methylphenidate, and the focus is on cardiovascular risk, and particularly the short-term risk. Here's a slide describing the study design. So this is a within individual comparison design. So what we do in this study is that we look at individuals with ADHD, and in this specific study, we're interested in the starting point of ADHD medication use. We identify that time period, and we look in this study 12 months before and 6 months after. And the question we ask is there an increased rate of cardiovascular events before and after treatment initiation within individuals? So that is the upper part of this slide. In this study, we don't always do that, but in this study, we also look at controls. So matched controls. The reason is that there could be things related to time and age. So it could be that cardiovascular events increase for everybody with time. So because of that, it's important to also look at individuals that are matched controls, and to see how cardiovascular events develops before and after a certain time point. So what we see in this study is that among those with initiating ADHD medication, there is a slight increased rate of cardiovascular events after the start of ADHD medication. We also see a slight increase in the matched controls, which is potentially expected given a slight increase in age. There could be other explanations to that, such as better coverage in the registers. So there are multiple potential explanations to that. When we compare the increased rate in those with ADHD and the controls, this provides some evidence of a small increase in the risk of cardiovascular disease related to ADHD medication initiation. An important question in this study, and an important question for many clinicians, is whether the potential increase in the cardiovascular risk is there both in those with and without cardiovascular history. So we performed or presented stratified results, as you can see here, and we find a slight increased risk in the cardiovascular risk, regardless of whether you had cardiovascular history or not. And we didn't find support for a statistically significant difference between those with and without the history. So the small increase risk is similar in those with and without CVD history. So the simple conclusion from this study was that individuals receiving methylphenidate treatment had a small increased risk for cardiovascular events, and we didn't find any support for differences in the risk between those with or without a cardiovascular history. So you will continue with 2 other papers.
Yes. So in the next paper, we continue with the question about cardiovascular risk associated with ADHD medication, but looking more specifically on the long-term risk. And here we conducted a so-called nested case control study. Again, we used the Swedish National Register data. And when we say a nested case control study, is a case control study nested within the cohort. And here the cohort is a cohort of individuals with instant diagnosis of ADHD in Sweden during this period. And after certain exclusion, we got about 250,000 individuals meet the inclusion criteria. And then during this about 14 years of follow-up, we identified a bit over 10,000 individuals who have an instant diagnosis of any cardiovascular diseases, range from something quite mild as hypertension to something more severe as myocardial infarction, for example. And then we matched these 10,000 individuals with cardiovascular diseases to 5 controls. So they have a 1 to 5 matched cases and controls. And then as in the case control study, we look retrospectively to examine their history of ADHD medication before the diagnosis of any cardiovascular diseases, and then examine the association between the cumulative exposure of ADHD medication and the risk of cardiovascular disease. And here we sort of see here the x-axis is the time of or cumulative duration, and this is the relative risk. We see sort of like a dose response relationship between duration and increased risk for the first 3 or 4 years. And then the risk sort of flattened out when we look at the more long-term follow-up. And so, I mean, the first part sort of, to some extent, mimics the results that we see with the first study. There's a small immediate increased risk, and then the risk continue to increase with the cumulative exposure, but then flattened out. But this flattened out pattern, is this something causal, or is this like some sort of selection going there? Because if we look at this very long follow-up time, this is not a trial. We're not randomizing people into 1 year, 2 year, up to 14 years of treatment. So if something pops up in practice, there are continuously increased blood pressure or any signs of cardiovascular problem, the patients may very likely drop off from the treatment or stop, or the clinicians may stop the medication. So this, when we look more into details to the youth and adults, we see more or less similar pattern. And then we look further into how the association may differ by dosage. And then here we stratify analysis based on the average dosage during the entire treatment course. And then we see here by for individuals with average dosage below 1.5 DDD, the DDD stands for the defined daily doses. We see almost no increased risk, but for individuals with average dosage above 1.5, we see about 4 to 5% increase with each additional years of medication use.
So how did you extract the information? How was it available in Sweden?
So in Sweden, we have use this so-called pretext prescription. So this is based on the prescription written by the clinician, and we use that information to define the daily dosage in terms of number of pills, and then together with the package information, we calculate the dosage. So that's one possibility. But actually, for this type of analysis, if we look at quite long term, we don't necessarily use the most precise prescriber information. We could just use, for example, the total amount of dispensed medication in a given time period, and then we could get the average dosage in the corresponding period. So I think that's could open up our possibilities, even if without such sort of detailed prescription information.
And that is available in Norway and
in many countries, I would say. So to sum up, we found that longer cumulative duration of ADHD medication use was associated with an increase or a small increased risk of cardiovascular disease. And I should emphasize these are primarily hypertension and arterial diseases. And the increased risk is only among individuals with a mean dosage with at least 1.5 times the DDD. And for the context, 1.5 DDD for methylphenidate, I think is 54 milligram per day. 36 is the DDD. Is the one standard DDD. So that is about the cardiovascular risk. And then in a more recent study, we look at ADHD medication treatment and the risk of mortality in individuals with ADHD. So we have done a lot of research on ADHD medication, which relates to its effectiveness, and also cardiovascular risk was considered as a safety or potential adverse effect. And then for a long time, we don't have a good measure of what is like the general or total effect on one's health. And we probably will never have one good measure on the total effect. But mortality could be like a rough index on like the general health or one of the hardest outcomes, so to speak. Here we have used a design named target trial emulation. And the idea is actually fairly simple. To use the clinical trial design feature to guide the analysis of real-world data or observational data, so that the result of the analysis of observational data would be as close as possible to the randomized controlled trials, and also at the same time avoid some common biases in the observational data analysis. And this target trial emulation design, I would say, is probably one of the most popular designs in pharmacoepidemiology in the last couple of years. And we have some faculty members from the International Society, senior faculty members, I would say, in the International Society of Pharmacoepidemiology here. So they can maybe back up or correct me with such a statement. But when we consider the design features in a trial, according to Miguel Hernan and colleagues who sort of designed this framework, there are 7 key components. And the eligibility criteria for defining the study population, the treatment strategy, the assignment procedure of the treatment strategy, follow-up, outcome, and causal contrast of interest and analysis plan. So here is what we would do if we could have a hypothetical target trial, and to make it more specific, it's like a pragmatic trial. So it's randomized but not blinded trial in real world setting. I will not go into details, but you will see many of the features in the emulation with observational data is actually the same as the target trial, or it should be the same. But the key thing is we can't do randomization in observational data, and that influence the treatment assignment and also the causal contrast of interest and the analysis. So what we do here is by following the recommendations from the Hernandez rule, is we use this so-called cloning, censoring, and weighting approach. To start with, the first step, we sort of do this cloning approach. For the target population or eligible individuals, we make 2 copies of each individual, and these 2 copies enter into the treatment arm and the no treatment arm at the same time. Sorry, this is antidepressant, but it stands for ADHD medication here. So then we have, as in randomized controlled trials, exactly 2 groups of individuals to the 2 treatment arms. And they are perfectly balanced with all the characteristics that either is measured or unmeasured. But we have only observational data. From the baseline, we start to observe these individuals. Soon we will realize some of the individuals, they do not comply with their assigned treatment. For example, in the initiation group, we will see up to the 3 months grace period, there are some individuals, they did not initiate the medication, so that they do not comply with the initiation group. Similarly, in the no initiation group, we will see some individuals do start with ADHD medication within this 3 months period, so that they do not comply with the no initiation group. So the point is, until we observe that they do not comply with the assigned treatment group, treatment strategy, the time until that, the time from baseline until that point, these individuals, they could contribute to both groups from baseline. And then we censor individuals when they do not comply with the assigned treatment strategy. But here, this censoring step is artificial and creates selection between these 2 groups. Then we have to do a weighting step to balance this censoring step to make sure those individuals remain in the group, either up-weighted or down-weighted, so that it remain balanced between these 2 groups. But the important thing here is when we do this weighting, we have to rely on measured covariates, both time-fixed covariates from baseline and time-varying covariates during this follow-up period. It's the same individuals. So basically, I mean, if we just think about the data set, we just copy the data set and create two rows for each individual with exactly the same information, except for the treatment strategy. Create these two copies at the very beginning when they meet the eligibility criteria, that is having a diagnosis of ADHD. And at that point, the individual could be treatment or no treatment. We don't know yet. And then we wait until we see what happened in the factual world, if they receive the prescription or not. And then we censor them accordingly. So with this somewhat complicated design and analysis, the result is actually fairly straightforward. We see as compared to no treatment, the treatment strategy is associated with about 20% reduced risk of all-cause mortality. And then if we look separately for natural cause of mortality and unnatural cause of mortality, we see a non-significant association for natural cause, a significant reduction, about 25% for natural cause of mortality, which is primarily driven by death due to accidental poisoning. I mean, there are many sensitivity analyses in the paper, as you have seen, and I mean, it always requires a lot of sensitivity analysis in observational data analysis. We have to test the assumptions. We have to see the robustness of the results due to various definitions of exposure and outcome. So among individuals newly diagnosed with ADHD, if we compare individuals who start treatment to individuals who do not start treatment, and then for those who start, they should continue with their medication and follow them up to 2 years. Within this time period, we observed a relative reduction of all-cause mortality by 21% compared to not initiate ADHD medication
during the full period.
During the full period. Yes, in the model we account for if they for the treatment group, if they sort of continue or persist with their medications. So that is, we censor them when they discontinue. So this is so-called observational analogy to the per protocol effect in the trials. Yes. So to sort of summarize, we in these 3 studies, we have used 3 different designs within individual comparison, nested case control, and target trial emulations. And I mean, what we want to say is, it's not because that we have these different tools and we want to show off so that we use different tools for different, but we do need different designs for different questions. And within individual designs are particularly useful for examining the risk within a relatively short period because it controls for time-stable confounding factors. But if we have a longer follow-up period or study period, the time-varying confounding accumulates and will influence the results. And then the nested control study is useful, or I should say quite convenient to do when examining long-term exposure or cumulative exposure. But it suffers from time-varying confounding to the same extent as other long-term studies. So we should always keep that in mind. And then the sort of the most popular approach these days, target trial emulation. as we look through the steps, we should also note that it solves some bias associated with time in observational studies, but still it relies on measured covariates to do the censoring weighting. So in other words, it could still suffer from unmeasured confounding or residual confounding from unmeasured factors, especially time-varying ones. So none of these designs would solve any particular or all the questions related to ADHD medication or any medication. I think it's most important when we have questions like this, we use the best available designs, but also we do triangulation with other designs and other data when possible. And when reading others' paper, the field have a lot of considerations in terms of how we could use real-world data to answer this type of research questions. And as we talked, it's not easy. And also, what we have done here is not flawless. There are issues behind these results. So, I mean, our research, we have sort of a number of things, both in terms of the practical consideration, in terms of how we analyze the data and how to interpret the data, and also clinical considerations. Under practical considerations, the first is confounding, and we have already touched on this unmeasured confounding and also time-varying confoundings in all types of pharmacoepi research or all type of studies related to ADHD medication. And this is related to sort of interpretation, writing up of the paper, and the use of causal language. I mean, for many journals, they still sort of very hesitant in terms of using causal language when reporting observational studies. They insist on using association with X and Y and never with the effect or the C word. But actually, with our latest paper, with the target file emulation, we actually have a discussion with the editorial team how to sort of phrase the result, because when using this emulation of target trial framework, it's almost impossible to describe it without using at least the word effect somewhere in the paper. I mean, this policy with no effect or causal word in the observational study, they come with a reason. And I understand why people are cautious, but there's also potential issues or potential need for change. And then another thing that we haven't mentioned, but we almost got review comments for all the papers, is competing risk. Especially now for ADHD research, we are taking the lifespan perspective into adulthood and older adulthood. So competing risk becomes an issue. But in addition to these practical considerations, we have further clinical considerations, probably more importantly. Henrik, would you like to?
Yeah, I can. Luckily, I think both of these examples that we want to bring up are things that we have already discussed. In particular, severity of CVD. In the first study, for instance, that I presented, we were interested in the short-term risk of CVD, and we used a quite broad measure of CVD events, even though we did focus on CVDs that could sort of develop in the short-term run. we used a quite broad definition. In the second paper, we did actually use both. We started off with a quite broad definition, looking at any CVD. And as we heard in this room, and also, from reviewers, from discussions in media, from in different contexts, everybody asks, but you're lumping together everything. We want to see more specific definitions of CVD. We want to see whether one common argument is the one that you brought up. We want to see if it's only hypertension or if it's something more than that. So that is a super important clinical consideration that we, as often as possible, should try to address in our studies. It can be quite difficult, in particular when we use a single country study, because we might not have statistical power to look separately at specific CVDs. But if we collaborate, if we combine data from different data sources, we have a better chance of looking at more specific CVDs. Type of medication, stimulant versus non-stimulant, is almost always a question that pops up. And sometimes we can address it, sometimes we can't. Sometimes it might not be relevant for the research question. So we have published a couple of studies on substance use disorder, for instance. We conducted such studies a couple of years ago, and the main concern was around methylphenidate. So for that specific research question, it makes more sense to focus on methylphenidate. But in other situations, it's reasonable to try as best as you can to look separately at both stimulant and non-stimulant ADHD medication. I could perhaps add to that. To some extent, I agree that it's important to come up with a conclusive study, but I disagree a little bit, because I don't think it is as simple as that. I think what we can contribute with is how to best prescribe to maximize benefits and minimize potential risks. And that could be, as you indicate, for some, doctors now have several different treatment alternatives that they can sort of use in different situations. I think the future of pharmacoepi studies could be help in improving how ADHD medication is used and prescribed.